get the slides up. What's that?
You take my mask off.
Yeah. Good morning, everyone. It's so good to see everyone. I'm glad that photos are being taken and we're all enjoying this space. It's so nice to see familiar faces, folks that we've spent so much time with over the last few years, but just not been able to actually be together professionally. So it's nice to see everyone here gathering. On behalf of my course co-director, Dr. Amanda Wieland, both of us would like to welcome everyone to Rocky Mountain Highlights 2022. I'm Swati Patel. I'm a GI doctor at the University of Colorado, as well as at the Rocky Mountain VA, and Dr. Wieland is a transplant hepatologist at both institutions. So we are so happy to have everyone here. We were very, very fortunate to be able to have this conference virtually over the last several years, but of course, as we all know, it's very special to be able to connect together outside of the isolation of our computers. So I should probably start every day with gratitude, but today I will definitely start with gratitude. There's some really important people that I'd like to thank to start our day. First and foremost, this course would not be possible without Christy Click, Matthew McLean. These folks have been so important in organizing this conference. Every single detail and logistic is because of their organization, their tenacity, their follow-through, and their support. So if you get a moment and you see them today, they may look a little bit busy, they may look a little frazzled, but please take a moment to thank them when you get a chance. I also would like to thank Lindsay Carter. She also is part of the team that helped us put this conference together. She's not here today for a very, very good reason. She delivered her little baby on June 6th, so for good reason she's sitting this one out, but we'd like to thank Lindsay as well for her support. The past few years have been challenging for all of us, and we'd like to say that we're on the other side of things, but it seems that there's something new that challenges us day to day, whether it's in our personal lives, our family lives, and certainly our professional lives. There's a presence that's missing this year. Dr. Hazem Hamad has been a really important team member and course co-director for us over the last several years. And unfortunately, due to unforeseen family circumstances, took a leave of absence and couldn't be here with us today. But he's here in presence and in heart. We miss his humor, we miss his presence and his really kind of enthusiasm for everything. Even when he sees garbage, he says that with gusto. It's garbage. But we're really, really happy to have worked with him on this course over the last several years. And we miss him today, but we know he's here. And so thank you to Dr. Hazem Hamad for how much work he's done at Rocky Mountain Highlights. On a similar token, I'd like to thank Dr. Steve Edmundowitz, who has graciously volunteered to step in and moderate the therapeutic endoscopy session. So we're really, really excited to not only have his expertise as a speaker, but also to be wrangling what will be a lively panel discussion. This conference, it's very important to us to make it widely available and accessible to all. And it's a commitment that we've had to make registration, continuing education credits completely free because we want everyone to be welcome at our conference. This would not be possible without the generous support of our sponsors. Many of you have already met with them and mingled with them before the conference has even begun, but I would like to specifically thank each and every one of them, and I hope you take the chance to do so today as well. We received educational grants from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, as well as an educational grant from Olympus Corporation of the Americas. We really appreciate that support. Our silver level exhibitors, AbbVie Incorporated Hepatology, Castle Biosciences, we thank them for our support. And then we thank all of our bronze level exhibitors, AbbVie Inc. PharmD, Bristol Myers Squibb, Cook Medical, Irby, Exelixis, Ferring, Fujifilm Healthcare Americas Corporation, Gilead Hep B, Gilead Liver Diseases, Intercept, Medtronic, Olympus, Avesco Endoscopy USA, Salix, Sanofi, Takeda Entyvio, and Takeda Gadix. When you get a moment, introduce yourselves, say hello to all of our wonderful sponsors, thank them. We have so much to learn from each other. The last few years have been difficult connecting with our partners in the industry, and this is a great opportunity to reacquaint ourselves with the folks that support us in taking care of our patients. To incentivize you a little bit to mingle, we ask you to check your attendee bag. There's a small passport, and if you get the chance to speak with 8 exhibitors, you'll be eligible to win one of 10 $100 gift cards. So if you kind of look around the room today, odds are pretty good. So make sure you get your gold star if you do end up having a nice, helpful conversation with one of our sponsors. And turn in your passport to Christy or Matthew at the end of happy hour. I know mine's might be a little bit fuzzy after a drink or two, but don't forget to turn your passport in because we'll draw the winners at the end of the conference. Just a few housekeeping items. A lot of these notes were conveyed to you at check-in, and there's information in your attendee bag. But today, the agenda is power-packed. We have 4 sessions. Each speaker in each session will speak continuously, and then we have ample time for panel discussion and questions and answers. We will have a first session on colon cancer prevention, followed by a break, and then we'll round out the morning with a session on therapeutic endoscopy before lunch. We'll then start the afternoon with hot topics in luminal GI, followed by a happy hour where adult beverages and snacks will be served. And then we'll round out the day with really important updates in hepatology, after which the raffle winners will be announced. I'd like everyone to take their smartphones out. I know most would say it's rude to have your phone out while somebody's speaking. This is the exception, so take your smartphone out, and there's no charge associated with these, but this allows you to participate with us throughout the day during the conference. So if you text the number 37607, so that's the recipient, 37607, and in the body of the text, just write the text CU GI-Hep. It doesn't have to be capitalized. And if you send that, that essentially connects you to our conference. And we'll certainly provide reminders on doing this throughout the day, but this will allow you to kind of participate in poll questions, and the audience response system throughout the day. So the number is 37607, and you can just text CU GI-Hep in the body of the text. And you should get a confirmation that you're connected to our conference. We got some thumbs up, some people still working. Okay, all right. We'll post those instructions throughout the day, so don't worry if you missed it. For those who need to connect their devices, the Wi-Fi code is Hyatt with a capital H22. If you parked in the parking deck, please make sure you check in with Christy or Matthew to get a voucher to validate your parking. And then for the happy hour, please check your bags for vouchers for the adult beverage that will be served later on in the day. And as I mentioned, don't forget to submit your passport. And word on the street is that some folks have already gotten a jump on getting their gold stars, so kudos. So many of you will be claiming continuing education credits. Certainly there's information that you can get at the front desk, but please make sure that you've registered and checked in with Christy or Matthew with your full name so that we can verify your attendance. You can do that anytime and cut away if you didn't get a chance to do so first thing. There's a QR code, and there's a different link whether you want CME and MOC versus the nursing credits. So just make sure you have the right link, and those QR codes are available at the registration desk. They're on our website, and they'll also be circulating during the breaks. So if you have any questions about that, let us know, and we can help you with that at any time. We're on social media. Maybe not all of us, but some of us are on social media. If you'd like to follow us, we're on Facebook and Twitter. You can kind of continue the conversation using the RMH 2022 hashtag if you'd like to. A few announcements from the division. One very important announcement, I'd like everyone to save the date September 19th to 20th for the 4th annual Dennis J. Anand lectureship. And so Dennis Anand is really a very, very important valued member of our GI community here in Colorado and a renowned expert internationally. And after his passing, a lectureship has been in place to honor his memory. And so it's really a wonderful opportunity for us to celebrate and honor Dennis. And this year, we're really excited to host Dr. Finley McRae. He's the head of the Colorectal Medicine and Genetics Group in Melbourne, and he's traveling all the way from Australia to deliver these lectures. He was a very close friend of Dennis's, so this is a very special lectureship. So save those dates. These conferences, more information will be forthcoming. They will be available to attend in person or tune in virtually, and we'll provide more information as time nears. Really interesting topics of wide interest to all, with I think which will be a very interesting international perspective. So more information forthcoming. Contact myself or Christy if you have any questions or if you're interested in donating to his lectureship fund. Really exciting announcement is, as wonderful as it has been for Amanda, Hazem, and I to lead this course over the last few years, we're really, really proud to hand it off to our new course directors for 2023, Dr. Blake Jones, Dr. Avash Kalra, and they will be starting the conference off today and ending it, so you'll get a flavor for their style. But we're really, really proud to be able to hand off this conference and excited for what they have in store for the conference. So as you kind of mingle throughout the day, introduce yourselves. If you have ideas for next year, please be sure to share them with all of us, but particularly Dr. Jones, Dr. Kalra. Thank you both for taking on this course. We have a power-packed agenda. It's available to you in your agenda bag that you can reference throughout the day. But what I'd really like to point out is that we are very, very blessed here at University of Colorado to have a really world-renowned panel of experts that we consider friends, we consider colleagues, but they are internationally recognized experts. So we're very, very happy that they're able to take time away, especially on a busy summer weekend day, to come speak at our conference, several of whom actually are flying immediately from this conference today to go on to do other conferences around the country. So we appreciate all of them taking their time today, and we're excited to have them. So that concludes kind of the housekeeping and announcements for the morning. And with that, I'd like to invite our first speaker for our first session. Our first session's on updates in colorectal cancer prevention, and I'd like to introduce Dr. Blake Jones. He's an assistant professor at the University of Colorado. He's the clinical quality lead and has specific expertise and training in informatics, particularly leveraging very kind of sophisticated techniques such as natural language processing, leveraging EHR modalities to monitor quality metrics. And so we're really excited to have his expertise to talk about optimizing colorectal cancer screening quality. Thanks, Dr. Jones.
Thank you, Dr. Patel and Dr. Whelan, for inviting me, and I'm excited to kick things off. As Dr. Patel mentioned, my name's Blake, and I'm a general gastroenterologist at the University of Colorado. And I have the privilege of starting things off by talking about optimizing colorectal cancer screening. I have no disclosures. This is what I hope to cover today in the next 20 minutes or so. I am going to be focusing mostly on colonoscopy because Dr. Patel is going to follow with a detailed talk on non-invasive methods of colorectal cancer screening. But I want to start things off with a discussion of where we currently stand with colorectal cancer screening in the U.S. We'll talk about a number of different colonoscopy quality indicators, emphasizing what's important, pay particular attention to the ADR, and we'll briefly touch on the impact of new technology on colonoscopy quality. So I wanted to kick off this morning with some good news, which, as we can all see from this graph, that the incidence and mortality of colorectal cancer has been decreasing really over the last half century. And some of that has to do with modifiable risk factors, such as the reduction in tobacco use, but a considerable portion of it is related to the increase in colorectal cancer screening in this country. And the arrow there points to 2001, when Medicare expanded coverage for colonoscopy to all individuals eligible for colorectal cancer screening, not just those with high risk. And we can see that that precipitated a pretty steep decline in both the incidence and to some extent mortality associated with colorectal cancer. Looking at it another way, from 2000 to 2015, we can see that the rate of patients undergoing colonoscopy for cancer screening increased by threefold, which coincided with a steep decline in the incidence rate of colon cancer. Though we can also see from this graph that really over the last 5 years or so, those improvements have started to level off. Furthermore, we know that specifically among younger age groups, there's backtracking or leveling off among both the incidence and mortality over the last 5 or so years, or even 10 years in terms of colorectal cancer incidence and mortality. And we also know that the success story of colon cancer outcomes is not equally shared across socioeconomic and racial groups. We can see from these charts the widening gap in incidence and mortality between blacks and whites over the last few decades. We also know that with the increasing burden of colorectal cancer among those younger than 50, that is unequally shared by blacks and Hispanics relative to their white counterparts. So where do we stand with screening currently? This is cross-sectional data from 2018, which is really the most up-to-date complete data that we have, looking at up-to-date colon cancer screening by state. We can see Colorado circled there somewhere in the middle. It's estimated that the overall rate of colorectal cancer screening in this country was about 66% in 2018. It may have upticked closer to 68 to 70% in 2020, but we all know the impact of the COVID pandemic probably severely adversely affected our ability to screen patients for colorectal cancer. And just as the outcomes in colorectal cancer are not equally shared across socioeconomic groups and racial groups, neither are the rates of screening. It'll be a surprise to nobody that those without insurance or who rely on community health centers have a far lower rate of colon cancer screening. And even those who are insured, those with commercial insurance, are less likely to be screened than those with Medicare. Some of that has to do with the age, but not all of it. So I really wanted to start off this talk by presenting this data for 2 reasons. One, I think I want to encourage all of us to think about quality and equity in the same sentence, and if we are undertaking any efforts to improve quality, we should be undertaking those efforts with an idea that we want to improve quality for all of our patients. The second reason is to present data that shows that the promise of colorectal cancer screening in this country is not completely fulfilled, and thus we should all really care about the quality of the colon cancer screening we're providing to our patients, which is what I'll spend the rest of this talk going over. I want to begin that part of the talk by emphasizing 2 resources that I think everyone who does colorectal cancer screening should be familiar with. The first one most of us probably are aware of is the 2015 guidelines that were published in GI-E by the ASGE and ACG about colonoscopy quality indicators. And the second is a clinical practice update published in 21 and by Kaswani et al. In Gastro that includes some up-to-date data as well as the newer surveillance guidelines for colonoscopy. So these are the quality indicators I want to touch on. With really 2 main foci, the first being those quality indicators that I think are helpful in improving or maximizing ADR, and the second set of quality indicators are those that I think are valuable in maximizing colonoscopy efficiency. And we'll obviously talk about the ADR and to some extent the cess-ulcerated detection rate as well. So beginning with cecal intubation rate, the value of cecal intubation rate in maximizing ADR is pretty self-explanatory. If we're not evaluating the right colon, we're likely to miss a significant portion of preneoplastic lesions. Thresholds have been set for cecal intubation rate, which is specifically 95% for screening colonoscopy, 90% for all colonoscopy. And I think just as important as cecal intubation rate is the knowledge that performing 2 exams in the right colon, specifically the ascending colon, is essential to maximizing ADR. 2 exams can mean 2 forward view exams or 1 forward view and 1 retroflexion. There's actually no data that says that one is better or inferior to the other, though I think those of us who do colonoscopy probably all can anecdotally recall polyps that we found in retroflexion that we would not have found in forward view. And I think most experts would recommend doing retroflexion in the right colon whenever it's possible. Moving on to bowel prep. So bowel prep is important because we know that an inadequate bowel prep is associated with a nearly 50% adenoma miss rate. It's something we should be tracking individually, but we should also be tracking as groups longitudinally. And there are thresholds that are set, really 85 to 90% for bowel prep adequacy among patients undergoing screening for colon cancer. The most commonly used scoring system is the Boston Bowel Prep score, which you're probably all familiar with, that assigns a score of 0 to 3 to each segment of the colon, 0 being the worst, 3 being the best. A score of 6 or greater has been associated with a significantly higher ADR than a score of 5 or lower, suggesting that there is not that much difference between the segmental scores of 2 or 3 for detecting adenomas. But I do want to point out that there's evidence, particularly in the right colon, that sessile serrated lesions are far more likely to be missed with segment scores of 3 relative to 2, thus emphasizing the real importance of an excellent prep for maximizing preneoplastic lesion detection in colonoscopy. There's multiple ways to improve the preps of our patients. Number one being using a split dose prep. There's clear evidence in randomized controlled trials that show that a split dose prep is preferable to all day before prep, both in terms of patient tolerance, but also in terms of improving prep quality. There's actually no evidence that patients have to do a clear liquid diet the day before their colonoscopy. A low residue diet is just as good and probably better tolerated by patients. So I think the main reason we all do clear liquid diet is because it's a lot easier to explain what that is to our patients. Which brings us to probably the most important part of improving preps, at least from a patient standpoint, which is providing detailed and frequent instructions. There's been several multimedia platforms that have been developed and studied for communicating prep instructions to patients. The one here up on the screen is from a study out of Korea that used a smartphone app to guide patients through their prep from up to 3 days prior to the colonoscopy all the way up to the procedure. We probably all don't have access to technology like that, but I think it does emphasize the point that if we are tracking our prep quality and we're not achieving adequate thresholds, then this is something we probably should be focusing on in evaluating the degree and quality of communication we're providing to our patients. And then finally, taking the time to clean the colon, both on the way in and on the way out, can severely impact the quality of your prep. There's evidence that doing things like water exchange on the way in can significantly improve prep quality, also improve patient tolerance, and even ADR. So speaking of time, the withdrawal time is a very important colonoscopy quality indicator because it's associated, or at least it's a surrogate for the quality of the exam, specifically on withdrawal when we're all looking for polyps. We're probably all familiar with the 6-minute cutoff that was recommended in the 2015 guidelines, and that was based on evidence that low-performing ADR providers tended to have shorter withdrawal times, whereas better-performing providers tended to have 6-minute or greater withdrawal times. But there's actually more recent data that we can see here from a study out of 2021 that showed that both the ADR and the rate of interval colorectal cancer improved all the way out to a withdrawal time of really about 9 to 10. So this would suggest that a 6-minute withdrawal time on a regular normal screening colonoscopy is probably not the optimal withdrawal time for maximizing ADR and colonoscopy quality, and we probably all should really be aiming more for it, at least a 9-minute withdrawal time, and that is actually what's recommended in that 2021 clinical practice update. Moving on, we generally tend to think of missed lesions as the primary driver of interval colorectal cancer, and that's true that does account for the bulk of interval colorectal cancer. However, we cannot lose sight of the importance of complete polypectomy. It's estimated that among some providers, there's nearly a 25% rate of residual neoplasia after cold snare polypectomy, and up to 30% of interval colorectal cancer can be attributed to incomplete resection. This graph over here on your right is from a study that looked at metacratous neoplasia, both from segments of the colon where adenoma was found or was not found on index colonoscopy, and clearly demonstrates a higher incidence of metacratous neoplasia on segments of the colon where there was an index adenoma, which could support the fact that incomplete resection was to blame for some of that. So a detailed discussion of correct polypectomy technique is probably beyond the scope of this talk, but I do want to emphasize a few points. Number one being that when removing polyps, we should all be trying to put the polyp really between 5 and 7 o'clock relative to the scope. We should be using cold snare polypectomy for all polyps greater than 2 millimeters at least, and then even consider using near focus or virtual chromoendoscopy to examine the polypectomy site to assure that all neoplasia has been resected. So colonoscopy is a relatively expensive resource, and any discussion of colonoscopy quality would be incomplete without discussing the efficient use of that resource, which brings us to the updated guidelines that were published in 2020 relative to colonoscopy surveillance. These guidelines were updated with data that generally suggests that the risk of advanced neoplasia following colonoscopy is not significantly higher for those colonoscopies in which just a few small adenomas are detected relative to a normal colonoscopy. I think this chart here does the best job in highlighting the main differences between the old and new guidelines, mainly being that we now have the option to extend out surveillance recommendations all the way up to 10 years for just 1 to 2 small adenomas or sessile serrated lesions, and even for 3 to 4 small adenomas or sessile serrated lesions, we can extend surveillance intervals up to 5 years. I do want to emphasize this presumes that all the markers of high quality colonoscopy have been met. And then just as important as surveillance after index colonoscopy is surveillance after subsequent colonoscopy, and the updated guidelines also provided new recommendations for this, namely that the findings of 1 to 4 small adenomas on index colonoscopy really do not any further impact recommendations after subsequent colonoscopy. They do not include any recommendations on what to do after sessile serrated polyp lesions are found. And finally, I want to highlight this graph from the updated guidelines because I think it does the best job in showing that the risk of really advanced neoplasia after resection of just 1 to 2 small adenomas is not significantly higher than if we did not find any polyps at all. And thus, I think this is what should really give us confidence in extending out those surveillance intervals to up to 10 years for those patients. I also want to use this to emphasize the importance and value in stopping colonoscopy in our patients over 75 who've had cumulative colonoscopies over only ever showing a few small adenomas. And then moving on to the coup de grace of colonoscopy quality indicators, which is the ADR. So the ADR remains probably the most important colonoscopy quality indicator because it has been shown over and over again that it is inversely correlated to interval colorectal cancer, which is the main thing, obviously, that colonoscopy is intended to prevent. It is also, just as importantly, relatively easy to measure when compared to some other proposed quality indicators. This has been shown, like I said, over and over again. So the standard incidence rates of interval colorectal cancer decrease as the ADR increases, and even for individual providers, if they improve their ADR over time, the hazard ratio of individual interval colorectal cancer decreases, and not just interval colorectal cancer, but interval colorectal cancer, advanced stage colorectal cancer, and death associated with interval colorectal cancer are also inversely correlated with ADR. So I think ADR thresholds is a bit of a moving target. We're probably all familiar with the 2015 recommendations, which recommended a 25% threshold for all colonoscopies. This was based on some older data, and there's actually newer data that suggests that 25% is probably too low. So this is a study that was just published this year, looking at a Kaiser cohort that showed that the hazard ratio of post-colonoscopy colorectal cancer improved all the way out to an ADR of between 35 to 40%. And similarly, the ratio of post-colonoscopy colorectal cancer-related death improved all the way out to an ADR of 30 to 35%. So this would suggest that 25% is too low, and we really should be aiming for at least 30 to 35%, if not higher, to maximize ADR or to maximize colonoscopy value. The main caveat with this study was that sessile serrated lesions were included in the ADR calculation among some of these patients. And then there's some question of whether or not there were enough providers included in the study with ADR over 40% to know for sure that there was no additional value in achieving higher ADR above that threshold. So I think there's always a question of how we define ADR. Historically and relative to guidelines, it's always been defined by indication, namely average risk screening. This does increase the labor of measuring ADR, and there's also a question of whether or not this allows for gaming of the quality indicator, as providers may be able to manipulate the indication for a given colonoscopy based on whether or not an adenoma was found. The good news is that there's pretty clear evidence that overall ADR, meaning regardless of indication, correlates well with screening ADR, and this is likely probably because the ADR among diagnostic colonoscopies and among surveillance colonoscopies relatively cancel each other out. So if we have to measure something, I would measure at least overall ADR if we can't measure true ADR, with the main caveat being that thresholds for overall ADR are not as well established. So what about sessile serrated lesions? Obviously, these are of interest to all of us who practice colonoscopy because they're preneoplastic and thus clinically relevant, and they are not typically included in the ADR calculation. The main caveat or weakness with sessile serrated detection rates is that they do rely somewhat heavily on your pathologists, and there's demonstrated high inter-observer variability among pathologists in assigning polyps, specifically in the right colon, as either hyperplastic or sessile serrated lesions. Again, the good news here is that your ADR likely correlates with your SDR, has been demonstrated in the literature, and thus if you're measuring ADR, you're likely assessing the performance in SDR among providers as well. There have been proposed thresholds, and this is of 7 to 10%, and this is based off kind of correlation with high ADR performing providers. So if we are tracking our ADR and we don't feel like we're meeting thresholds, what can we do to improve ADR? Well, I think the first thing we can do is we can go back to the basics. We should be making sure we're doing everything we can to optimize the bowel prep for our patients, leveraging the things that I talked about before. And then just as importantly, we should be taking our time on withdrawal, not just to meet the 9-minute threshold, but because we need to take more time to look behind folds, clean the wall of the colon, et cetera. So what about mucosal exposure devices? There's a number of different options. I'd say that really there's only strong data that shows that endocuff is superior to just regular forward view high definition white light endoscopy. And probably all of these are going to fall out of favor due to the uptake of artificial intelligence. There's also evidence that chromoendoscopy can improve ADR, though it's probably impractical to use chromoendoscopy in all screening colonoscopies. One of the reasons we should be measuring ADR is because there's clear evidence that just providing feedback in the form of report cards or any other platforms can improve ADR among low-performing providers, as can attending talks about improving your ADR or shadowing experts in the field, watching videos, et cetera. And then finally, we're probably all aware of the promise of artificial intelligence in neoplasia recognition, and that is something that we're probably going to all be seeing a lot more of in the near future. Speaking of artificial intelligence, I think if any of us have been to DW or any other conference in the last 5 years, you've probably been inundated with articles detailing the marvels of AI in GI and colonoscopy specifically. I think the greatest promise probably lies in neoplasia recognition and computer-aided diagnosis. And there is actually now some real-world experience with that. The first FDA-approved platform in the US occurred in April of last year, and I think another one was approved just recently this year. And this data up here on the screen is from a study actually of an Italian cohort that looked at that AI platform and showed a 30% increase in the ADR among providers using a computer-aided diagnosis. Similarly, looking at the same platform in a meta-analysis that was published recently, we can see that the adenoma miss rate was decreased by 2-fold using computer-aided diagnosis. So I think there's clear evidence that computer-aided diagnosis will help improve ADR and reduce adenoma miss rate. I think the jury is out a little bit somewhat on whether or not this will, or how this will impact post-colonoscopy colorectal cancer. There's some question of whether or not AI is better at recognizing flatter and smaller lesions. And I'd say for proceduralists who are already achieving an ADR of 40% or greater, we don't know what additional percentage points above that using artificial intelligence will do to impact overall colon cancer outcomes. So I'd say just to close that if we are all practicing high quality colonoscopy, following guidelines and expert opinion, measuring our performance, and doing whatever we can to improve, there's a chance that we can stave off the supremacy of artificial intelligence for at least a little bit longer. And that's all I have. Thank you.
Great. Thank you, Dr. Jones, for really an amazing overview of how powerful high-quality colonoscopy can be. So I'll actually take the time that we have in this session to talk about the non-colonoscopy options that we have. So some of the non-invasive colon cancer screening modalities. These are my disclosures, no bearing on the content that we'll talk about today. So first, I'd like to just take a step back and really go over why we're even having this conversation. Based on everything that Dr. Jones presented, colonoscopy has been highly effective at decreasing colon cancer incidence and mortality in this country. Why should we even be thinking about a colon cancer screening modality besides colonoscopy? We'll talk about what different non-invasive options we have and some really, really exciting things that we think we'll probably see over the coming years. So why should we think beyond colonoscopy? Well, when we think about an effective screening test, so this is screening for cancer, screening for heart disease, any test where we're thinking about the health of a population, we ideally want a test that has good test characteristics, meaning it's going to pick up as many patients with the disease as possible, so high sensitivity. We want a test that's ideally acceptable to our patients, affordable, and available or accessible to them to really get the test. And if all of these tests have these characteristics and are applied to a disease that's common, has a large public health burden, can be detected in a preclinical stage, meaning before a patient develops symptoms, and if we do detect it in a preclinical stage, we can actually do something about it, that's really the makings for an ideal, successful screening program. So as Dr. Jones mentioned, screening colonoscopy has been highly effective in our country. We've seen a steady decline in the incidence and mortality, and that's in large part due to the uptake of colonoscopy. And he showed you this, that as we've seen colonoscopy rates increase, we've seen a parallel decrease in colon cancer incidence. Landmark kind of trials really demonstrated that colonoscopy with adenoma removals associated with up to a 90% reduction in colon cancer incidence and up to 53% reduction in death from colonoscopy. Multiple subsequent large cohort studies in the United States, outside of the United States, within different types of health systems, such as the Kaiser system, the VA system, have shown that colonoscopy is associated with decreased incidence and mortality from colon cancer. So why? Why would we even think beyond colonoscopy if it is as effective as we know it can be? Well, it's also because of the data that Dr. Jones showed us. When we look at the uptake of screening rates across our country, they're quite disappointing. In Colorado, less than 70% of 50 to 75-year-olds are up to date on colon cancer screening, and that's not even including the expansion recently of 45 to 49-year-olds. And when we break that down by age group, the results are even more disappointing. Only about 50% of 50 to 54-year-olds are actually up to date with colon cancer screening. So it starts to really beg the question, is colonoscopy really the most acceptable and affordable option? Well, we all know and really review with our patients every single day before every procedure the potential risks that go along with colonoscopy. It's overall a very safe, very well-tolerated test, but when we're talking about screening hundreds of thousands of people for a kind of a screening program, these risks of bleeding and perforation are real. Patients always are concerned about cost, and appropriately should be. Now, the Affordable Care Act really does mandate that U.S. Preventive Services Task Force recommendations, such as colonoscopy and colon cancer screening, that are graded as grade A, should be offered to patients with no cost sharing, meaning it shouldn't really go towards a copayment, a deductible, shouldn't require co-insurance. But we all know that it's not as simple as that. There's, of course, the opportunity cost of taking a day off of life, family, work to come in for the procedure, let alone the person that has to escort the patient for the procedure. There are costs associated with that, even if the actual test is reimbursed by a specific insurance company. And then, of course, there's the myriad barriers that we encounter based on patients' perceptions of the test, based on different beliefs and different subgroups that have fears about the test, different uptake based on socioeconomic status, different gender issues. And so we know that these barriers are things that we encounter with our patients, and it's a very, very common occurrence, particularly at the university. It's quite stark, where you see a colonoscopy order from 2019, a colonoscopy order from 2020, 2021, 2022, and these are just all active orders, and the patient never ends up scheduling. The other issue that's really important to think about is how accessible is colonoscopy? Well, we know that unfortunately we've observed an increasing rate of colon cancer in younger patients. This is a very, very alarming trend. We've talked about it in this conference in the past. And in response to this alarming trend, our professional societies have responded by expanding screening. This is a really important step to decrease the burden of cancer in these younger patients. And this started with the American Cancer Society back in 2018, who recommended expanding screening to 45 to 49-year-olds, and subsequently was supported by the National Comprehensive Cancer Network last year, the American College of Gastroenterology, our United States Multi-Society Task Force, which is a combination and represents the ACG, the AGA, and the ASGE. And then, of course, the really important change was by the United States Preventative Services Task Force, which graded expanding screening to younger patients as a grade B recommendation. So what does that actually mean in terms of how many more patients we have to screen? Well, this is data from the US Census Bureau. And if we look at the individuals ages 45 to 49, that essentially adds 21 million adults that are now immediately eligible to get colon cancer screening. When we look at our system specifically, we pulled this data last year. The University of Colorado system in Colorado has almost 150,000 individuals ages 45 to 49 who would technically now be eligible for screening. Many folks who work in the endoscopy labs, this is a substantial burden of patients to really accommodate for screening colonoscopy, particularly with the delays that we've incurred because of the COVID-19 pandemic. In the VA system, we've got our strong VA contingent here, can attest to some of these numbers, but we do approximately 280,000 colonoscopies nationwide a year. If we look at the number of 45 to 49-year-old veterans in the system, that's actually almost exactly that same number. So when we think about the VA capacity to do colonoscopy, in 2021, there were 1.6 million veterans who now were eligible for colon cancer screening in a system that only does less than 300,000 colonoscopies a year. So there's a huge mismatch in our capacity if we're really thinking about colonoscopy as our only modality. The other thing to think about is that even though we know colonoscopy is highly effective in decreasing the colon cancer incidence, many who participate in colonoscopy screening blocks, you can go a full day of 18 colonoscopies, consecutive days, even weeks, without necessarily diagnosing a colon cancer. And that's what the data shows, that in average risk individuals, those who have no family history, no symptoms, the rate of finding colon cancer on just kind of routine screening colonoscopy is pretty low. We find it in 0.2% of patients that we do screening exams on. Now, of course, we find lots of polyps and other conditions that we help patients with, but in terms of the goal of finding cancer early, we find it in 0.2% of average risk individuals when we do screening colonoscopy. So it starts to really raise the question of, rather than trying to use colonoscopy to find that needle in a haystack, are there ways that we can actually just scope a big pile of needles? So where are we now in terms of what non-invasive colon cancer screening options we have available to us? Well, when we think about our screening modalities, we essentially divide them into three categories. There's blood tests, stool-based tests, and structural tests. And many in the room are highly familiar with all of these. So when we think about these tests, it's important to know what they're designed to detect on the spectrum of precancer to cancer. The structural tests, such as colonoscopy, CT colonography, capsule colonoscopy, those are tests that, of course, are designed to detect cancer, but can also detect and ideally remove precancer. The stool-based tests, essentially, the concept of a stool-based test is to really use the stool and anything that's shed into the stool to potentially screen for cancer. And those tests are generally designed to detect cancers before they develop symptoms. So blood that's shed from the stool, DNA markers that we'll talk about. The blood test that we have available to us, we'll talk about a little bit, but has been historically disappointing because it really relies on what tumors may shed into the bloodstream. And by that time, oftentimes these tumors are advanced stage. And so really historically have only detected invasive cancers. Thankfully, that will change likely. So when we think about all of these tests that we have available to us, it's really important to understand that all these tests besides colonoscopy are considered two-step tests, meaning these tests are initial screening exams, and if they're abnormal, require a follow-up colonoscopy to check out what's going on. These tests are not specific for colon cancer. So really, to complete screening, it's only as effective as if that patient actually gets to that colonoscopy to diagnose whether that stool-based test or that blood test was abnormal because of a cancer, because of a polyp, et cetera. So if we talk about kind of the most commonly used options available to us, what do we have data for? Well, we actually only have prospective randomized controlled trial data for fecal occult blood testing, the first generation of stool-based tests, and flexible sigmoidoscopy. So those are the only modalities that we actually have prospective data comparing screening to no screening that shows a benefit to colon cancer-related mortality. With that said, we know a lot of these other modalities are quite effective, and there's kind of cohort data that's very, very strong that Dr. Jones and I have showed you a little bit of, for instance, with colonoscopy. But with these other newer modalities, there really is limited data. But based on these tests, based on the data that we have available, all of our professional societies essentially have come to a consensus to offer a menu of screening options to our patients. The only thing that I'll point out is that although the USPSTF, NCCN, and ACS offer kind of a menu of options in sort of an equal way, our multi-society task force actually suggests a tiered approach to screening. Tier 1 exams being colonoscopy or fecal immunochemical testing, Tier 2, FlexSig, FIT DNA, or CT colonography, and then Tier 3, capsule. We'll talk about these tests a little bit. So the stool-based test, the first generation, was the old school fecal occult blood test. And there's probably folks in this room that have experience with these cards. The patient would go home with these cards, would have to essentially smear stool on 3 successive different bowel movements. And they would return these cards, the stool would be rehydrated, and then a little peroxidase reagent was placed on the stool card to check for this reaction to the guaiac, and essentially would determine and tell you whether there was hemoglobin present or not. Unfortunately, it really wasn't specific to human blood, and so we had to tell patients to avoid certain dietary things where they could get hemoglobin through their diet, such as through meats. We wasn't really specific to the location in the GI tract, and so we asked patients to avoid nonsteroidals, aspirin, because if there's little gastritis, that could cause a false positive. And it required annual testing. So you can see this is a very cumbersome test to tell a patient to poop on a card, at home, mail that back in, and analyze this. The other piece of it is that it was qualitative. So they just we put the little dropper on the card, and it sort of changes a color, maybe doesn't change a color. And we are all familiar with, home-based tests like that. But it didn't really provide quantitative results, numbers to kind of get a sense of, well, how much blood? The next really important thing to talk about, though, is that back in the 90s and early 2000s, there was really a series of studies that were published using fecal occult blood testing on a population level, here in the US as well as in Europe. And these are hundreds of thousands of patients. The largest study had over 150,000 patients who got regular fecal occult blood testing. And consistently, every single one of these studies showed that fecal occult blood testing programs decrease death from colon cancer on a population level. So it works compared to no screening. The next generation of stool-based tests is the FIT test. And this is the most commonly used test, particularly in large systems such as Kaiser and the VA. But this test is actually specific to the human globin protein. So it's specific to humans, it's specific to globin, which thankfully then makes it specific to the lower GI tract, because globin is broken down in the small bowel, and so if it were hemoglobin from the upper GI tract or the small bowel, it would have been broken down. By the time it got to the colon, it wouldn't cause the FIT test to be positive. So FIT provides quantitative results of concentration of globin per kind of deciliter of stool. And it's specific to the colon and humans. So we don't have to make our patients take any restrictions. It's a single sample as opposed to 3 successive samples. This one we still also recommend annually. And then, of course, the newest kid on the block is multi-targeted stool DNA, or essentially a combination of fecal immunochemical testing and DNA markers. So this is a combination of the FIT test plus various DNA markers that can be shed into the stool that may be associated with precancer or cancer. And this test is recommended to be done every 3 years. So how do these stack up to one another? Well, the great news is that the sensitivity, so these test characteristics that we care about, improve with each generation, where you can see that the stool DNA test will pick up 9 out of 10 cancers. FIT picks up 8 out of 10 cancers. But it's important to note that this is sensitivity for cancer, not precancer. Many of us who do colonoscopy, we're really interested in the sensitivity for precancerous polyps, but you can see that really the sensitivity for precancer polyps is around 50 to 60% at best. It's also important to note the differential cost. You can get a FIT test for under $30. Stool DNA, depending on the setting, can be as expensive as $600. CT colonography is a test that's certainly available. We do in very specific scenarios, not as widely used. This is actually now almost a 20-year-old paper from the New England Journal showing how CT colonography can reconstruct images from the colon to detect polyps. And it has actually pretty good sensitivity for large polyps. The problem with CT colonography is that it does not necessarily have good sensitivity for these flat lesions. And so we're all familiar with these large flat lesions, serrated lesions that are just as precancerous as big protruding polyps. And CT colonography is limited in detecting these lesions. And this study showed that there was a significantly lower rate of even detecting high-risk sessile serrated lesions, so high risk based on size, based on histology, compared to colonoscopy. Capsule colonoscopy is a somewhat newer test that's also considered a structural test. It's very similar to a small bowel capsule. It requires a purgative bowel preparation and can capture images as the capsule sort of migrates through the colon. And as expected, it has a pretty good sensitivity for adenomas, even adenomas less than 10 millimeters. But the sensitivity for sessile serrated lesions leaves a little something to be desired. So our societies support a menu of options. I guess the most practical question is, what's the best test? What should we tell our patients we should be doing? Well, I might just be controversial here and ask us to pause and think back to what the purpose of screening is. We want to decrease the public health burden of colon cancer, the second most leading cause of cancer-related death. And so if we put these tests together, we know that colon cancer is the perfect disease that is suited for screening. We can really do something about it if we find it at early stages, whether that's an early cancer that can be cured with surgery or a precancer that can be removed. How do things match up if we put these tests next to each other side by side? Well, if you compare the sensitivity for cancer, sensitivity for advanced polyps, it seems like it's a no-brainer that colonoscopy is the winner. I think the issue that we have to take into account is that there's probably a little bit more to it. What about the affordability, the accessibility, and how acceptable it is to our patients? This was a really interesting study in Poland that recruited over 12,000 patients and essentially randomized them to being offered colonoscopy, and then if they declined a FIT, or just a choice. And what they found is that the adherence rates for colonoscopy were not great, about 17.5%. Better, but still probably lower than what we would like to see here in the United States, but better for those who got sequential offer, that if they declined colonoscopy, then they got FIT, and about the same if they were given a choice. What's really interesting is that the detection of advanced lesions was the same across the board, even though we know that colonoscopy is superior in terms of sensitivity for adenomas, sensitivity for cancer, but it's really because so many more people were screened with the stool-based approach or the choice approach. And so it starts to really raise the question of whether we need to take other factors into consideration when we're thinking about the best screening modality for a population. And things like cost and adherence really do have to play into our decision making. So I think when we think about the best test, it's really the test that gets done. So certainly when we're having conversations with our patients, that's probably the most important thing. But as a society, I think we'll learn the answer to some of these questions of what actually impacts colon cancer incidence and mortality in a population as we get results from a series of really large studies that will be completed over the next 5 to 10 years that are comparing these different strategies. So at the VA, we have the CONFIRM study that's randomized 50,000 veterans to either annual FIT or one-time colonoscopy, and we'll see what the colon cancer mortality rates are at the end of 10 years. Studies that you can see in Europe, that are also looking at different strategies. So I think we'll have the answer to how we address this as a society, but I think in the short term, as we talk to our patients, the best test is the one that moves the needle forward and the patient will actually get done. So I'd just like to spend the last few minutes talking about some exciting things coming down the pike. So stool-based tests historically have really looked at bloodshed in the stool, DNA markers, but we also have learned a lot about the microbiome and how there's different bacteria that are specifically associated with cancer. And this study looked at adding a bacteria to our fecal immunochemical testing assays, and it actually significantly improved the sensitivity and specificity for cancer. And so I wouldn't be surprised if a future generation of a stool-based test incorporated some component of the microbiome. I told you that the blood tests aren't really used. Although it was approved by the FDA back in 2014, none of our guidelines actually recommend using a blood test. And the really rationale for this blood test, Septin9, is that there's DNA markers that can be shed into the blood, and the blood test can essentially do analysis and do PCR to detect those. But unfortunately, the sensitivity for early stage disease, where we want to catch cancers, that we can actually do something about it, is pretty low. These blood tests can catch, really at most 60% of cancers. And so they haven't been used, but what's really encouraging is that there's a lot of development in this field. So the FDA and really Medicare essentially came out through CMS with 3 criteria that will require to be fulfilled in order for a blood test to be used for colon cancer screening. One is that it has to be approved by the FDA. It's fairly straightforward. The other is that it has to have a sensitivity greater than 74% and a specificity greater than 90%. So what's really, really encouraging is that there's a lot of development in this field such that the blood tests that are currently available and will be available over the next few years will have much, much higher sensitivity along the cancer spectrum. To just share a little bit about that, historically it was really just DNA markers in the blood, and now we really have the ability to detect epigenetic alterations as well that are kind of markers of colon cancer. And then non-tumor circulating cells, so immune cells that have been associated with cancer. And leveraging these things, a variety of different organizations have developed panels that can now have really high sensitivity for detection of cancers. And so to show you some of that data, this was presented at ACG and then again at DDW this year, but this is a blood-based test, and you can see that the overall sensitivity for detecting stage 1 through 3 disease was 96%. So this actually performs better than stool DNA and FIT. And when we look at stage 1 and stage 2 disease, it's actually quite good, 88 to 98% to detect very early stage colon cancers. When we look at the patients who had no symptoms, so our average risk population theoretically, for those who had no symptoms, the detection of early stage disease was 90%. It's very, very promising. Similarly, they compared specificity, and they compared this to our established tests and showed that the overall specificity for early stage cancer was 94%, and significantly better when compared to our fecal immunochemical testing and the older plasma circulating tumor DNA tests that we don't really use. So we know that adherence will likely play a big factor in how these blood tests are incorporated into colon cancer screening. This was a study where patients were offered screening. 37% chose colonoscopy. Of those who didn't want colonoscopy, only 3 completely refused screening. The remaining of those who refused screening wanted a non-invasive option. And of the non-invasive options available, 15% chose a fecal test, and 83% chose a blood test. This really is not surprising. Of course, if you went for your annual visit and your doctor said, hey, I can also add a blood test for colon cancer screening, what do you think? Well, you're already checking my lipids and my thyroid. Sure, it's another vial of blood, right? It's very intuitive. I think what's really nerve-wracking about these tests to keep in mind is that, yes, they have sensitivity for detection of colon cancer, but it's not specific to colon cancer. There's a variety of different other cancers that they can detect, so it's a bit of a Pandora's box in how we approach the multitude of cancers that these blood tests might have the ability to detect. So we add a few more rows to this table. Blood-based screening, I think, is going to become a big part of average risk screening. The cost is substantial, especially since we know it's a 2-step test where abnormal tests will have to followed up by colonoscopy. But I think the promise is in its adherence. A few other tests that we might hear about over the coming years will be CT capsule exams and then MR colonography as well. There's a lot of challenges with two-step tests. We certainly have talked about some of them as we've gone. Adherence to more frequent testing will be an issue in navigating patients through getting regular screening and navigation to a follow-up colonoscopy. Cost is a consideration. And then coverage for the follow-up colonoscopy, and we've had some recent developments on that. And then really discordant results. And so I wish we could kind of dive into all of these issues today, but for the sake of time, I'll just talk about this issue of discordant results. So what does that mean? That means when that first test is abnormal, but then the follow-up test, the colonoscopy, doesn't show anything abnormal. And so this was a study that demonstrated that really for patients who had abnormal fit fecal DNA with a follow-up normal colonoscopy, there was no difference between really the long-term risk of developing a GI cancer. And so the conclusion from this study and the consensus from our professional societies is that if a patient undergoes a high-quality follow-up colonoscopy, it doesn't require any additional testing. So we don't recommend for abnormal fit fecal DNA to do other upper endoscopies or small bowel endoscopies or repeating the colonoscopy as long as the colonoscopy was of high quality. So I think there's a few directions that are we're gonna see over the coming years. We'll certainly have comparative data regarding what tests might be the best for a population, fit versus colonoscopy. As our system hopefully over time moves towards value-based medicine and focusing on the full population, so as Dr. Jones mentioned, thinking about equity and really ensuring access to colon cancer screening for all populations. I think in general, the best test is the test that gets done, but how that is implemented to reach everyone, we'll have more to come. I don't think colonoscopy is going anywhere. I speak as a gastroenterologist who loves doing colonoscopy. I think it's just gonna be different. It's gonna be a lot more second step tests, diagnostic exams, therapeutic tests, and with that, an evolution of the quality metrics that Dr. Jones mentioned in terms of our kind of lesion detection rates. And I think we're going to continue to struggle with desynchronous results, particularly these blood-based tests, if we don't find something on the follow-up diagnostic testing, and then of course, as always, the cost of the system. So I'll conclude with that. I thank everyone for their attention this morning in our first session. We do have some time for question and answer. And so as folks are thinking of questions, I'll encourage you to come to the podium. If you'd like to shout out your question, that would be fine too, and we can repeat it. But as people are thinking about questions, I have a question for you all. So based on Dr. Jones's presentation, what is the optimal target for adenoma detection rate in average risk screening colonoscopies for all comers? So average risk means individuals who have no family history, no symptoms. What do we think is like the average kind of target adenoma detection rate? What should we be aiming for? So remember, you can text, the number to text to is 37607, and if in the body you just put CU GI-Hep, and then you can enter your answer, A, B, C, or D. Dr. Jones, what do you think about how these numbers are playing out here?
So yeah, I think, well, you can all hear me, right? I would say that I agree. C or D is probably the right answer. I think we probably don't have the data yet to know for sure. I think for now, we should at least be aiming for C. And as we get better and better at detecting more subtle lesions or smaller lesions with the use of AI, we may find that an ADR of 40% or even higher gives us additional benefit. So I think I agree with the audience. Excellent.
So don't be shy. I know it's the first session of the morning. Please give us questions if you have them. But as we conclude this poll, I can pose another question to the audience. What do you think is the best colon cancer screening test? This is a personal question. There's no right answer. What do you personally think in your life, your family, your practice is the best colorectal cancer screening test? This is great. So I think everyone attended my talk, but this is exactly the issue, right? If colonoscopy can get done, and if it can done in a high quality fashion, it truly is likely the best test. But the key is, can we actually get people to their procedures, and can we get a high colonoscopy procedure completed? So we haven't really swayed minds too much on some of the non-invasive tests, but I tried. Questions from the audience about colon cancer screening, issues or controversies that you've encountered or challenges in screening in your population? Yes. And introduce yourself, please. Mm-hmm. Yep.
And then they will no longer cover the colonoscopy 100% because at that point it's diagnostic.
That's a great question. So Kim Cox from the VA asked the question of if that first step of the screening test is considered the screening test under the Affordable Care Act, that should be no cost sharing. Is that second test considered a diagnostic test, and is that cost to the patient? That has been a very, very real issue and real concern. And there's actually just been very recent change in that because we have been dealing with that for years. So in January of 2022, the Biden administration essentially put out a clarification to say that the definition of screening is completion of screening from the first step all the way to completion of colonoscopy. And they gave all commercial insurance companies until May of 2022 to incorporate that into their coverage. And so that's sort of the donut hole, that people were talking about. And there was a lot of legislative action by multiple professional organizations, including the AGA, including patient advocacy organizations such as Fight CRC. But it was in January of just this year that they were able to clarify that on a federal level as a kind of a clarification to the ACA, such that that should not be the case. Now, does it still happen? Yes. The insurance companies were given until May of 2022 to really correct these things. But just as anything, it takes time to sort of implement, but that really should be, addressed on a national level. Prior to that national mandate, states were trying to deal with this on a state-by-state basis. And so the state of Colorado, we had, a lot of work proposed to the legislation to try to close it on a state level. And thankfully, we really didn't have to continue pursuing that because it's now addressed nationally. So if you encounter that, there is support to fight it. Please, disseminate the message that completion of screening is now covered from the initial first step test to the screening colonoscopy, the follow-up colonoscopy. Okay, looks like we have a question here.
My name is Inger Fetty, and I think I'm your minority of target audience because I'm primary care here. So my issue is with the above 75 group, where I assume that incidence with age increases. And I get if you reach the age of 75 with negative screening up to that point that you're no longer screening. But it's the question of the patients with IDA or high risk lesions before. And oftentimes I'll end up just referring to GI to have that risk benefit conversation, but I'm going to a place where there's less access, and I don't see good guidelines for that. It's always kind of that risk benefit question.
Yeah, Dr. Jones, if you want to take that.
Sure. I think that is an area where we don't have the guidelines and the greatest data at this point, though I will emphasize the important point that colonoscopy, a normal screening colonoscopy is protective probably for longer than 10 years, as is a colonoscopy from a high quality provider where even just a few small adenomas are detected. So I think it's pretty clear for people with a low risk history. For people with a high risk history, it does come down to the cost benefit discussion with the individual patient and allowing the patient, I think, to weigh in and The patients who've had a high-risk adenoma should probably get follow-up colonoscopies past the age of 75 if they're in relative good health. And by relative good health, I generally tend to think life expectancy of at least 5 to 10 years. But I agree that right now there is not, I think, clear data to guide us in that area, which is why I advocate kind of a mutual decision-making approach and on a per-patient basis.
Yeah, and I think I might add the scenario that you bring up is really important. It's sort of the difference between a diagnostic exam versus a screening or surveillance exam. You know, for a patient with new iron deficiency anemia or hematochezia, those are red flags. And if they've not had a thorough evaluation, and as long as they can tolerate the procedure and would like to know the results, that's the conversation that we have with them in clinic, and that's the one that we honestly very much rely on you to have. And if you feel that your patient can tolerate the prep, tolerate the anesthesia, have a conversation about safe sedative, safe anesthesia if they have comorbidities, you know, my colleagues at the VA will attest, we do diagnostic exams in 80 plus, sometimes 90-year-olds, if it's somebody who's independent, well, and would want to know if they have a colon cancer. Great, so I think we will close out this very important session this morning on colon cancer prevention. I thank everyone for your attention. We will reconvene at 9:20, so if you missed coffee or breakfast, please feel free to get some. Please say hello to the vendors and sponsors, and we'll reconvene at 9:20. Thank you very much, everyone.